Hello, everyone. My name is Mary Ellen Shannon. I'm a Senior TA Manager with SAMHSA's State TA Project. Thank you for joining our webinar, Taking Action Using Research-Informed Strategies to Reduce Problems and Promote Health in Older Adults. This is the fourth in the Substance Abuse Among Older Adult webinar series. For those who did not join us earlier, I'll let you know how to access the recorded webinars, PowerPoint presentations, fact sheets, and all the other resources from the webinars within the series. But first and foremost, I want to be sure that everyone is hearing a clear broadcast and knows how to participate. So if you are having any technical difficulties, please send a message using the chat function to JBS IT support, and they'll help you out. We encourage you to submit your questions at any time during the broadcast by selecting Host or Basela Raya in the drop-down menu of your chat window. And to open your chat window, simply click on the chat icon at the upper right side of your WebEx window. The phone lines will stay muted to ensure a clear recording of this event. And if we don't get to your question during this broadcast, we will develop a question-answer document that will be available to all participants after the broadcast. I'm required also to disclose to you that the webinar is being recorded and that by participating, you are consenting to the recording. We do request that everyone also participate in a short satisfaction survey that will appear in a pop-up window once the session ends and you close out of the webinar. And we thank you in advance for your participation in this survey, which helps us continuously improve our services to you. This webinar series is designed to draw attention to substance abuse among older adults and explore solutions to stopping this growing problem before it becomes an epidemic. Some of the other topics that were included in the series include high-risk alcohol and opioid use among adults ages 55 and older, opioid issues and trends among older adults in rural America, and taking action, mobilizing partners to address substance abuse and misuse issues among older adults in their state and community. During today's broadcast, we will feature 3 presenters. Our first presenter, Dr. Fred Blow, will provide an overview of the screening, brief intervention, and referral to treatment evidence-based practice used to identify the prevention, intervention, and treatment needs of older adults. Dr. Blow is a professor of psychiatry and the director of the Addiction Center at the University of Michigan's Medical School. He's published over 350 papers and several books and is a national expert, career researcher, and educator in the field of alcohol and substance use screening, interventions, and treatments. His expertise also includes demonstrating the effectiveness of using SBIRT with older adults. Our second presenter, Amy Miller, will provide an overview of the Senior Reach program. Amy is a licensed clinical social worker and the Senior Reach National Consultant. In this role, Amy helps organizations interested in bringing the program to their community to determine which stakeholders need to be involved, how to obtain financial support for the various components of the program, and how to problem-solve potential obstacles and capitalize on the existing strengths of their community. She also oversees the day-to-day operations for the Senior Reach site in Jefferson County, Colorado. Our third presenter, Dr. Christina Economos, is a national public health expert. She has served on 4 National Academies of Sciences, Engineering, and Medicine committees, and will introduce us to the Academy's LEAD framework, which was developed to help planners and practitioners identify effective approaches to problems for which few strategies have been documented to be effective. Dr. Economos has authored more than 150 scientific publications, and her work has been featured on CNN, NBC, The Wall Street Journal, and Newsweek. Before turning this over to our presenters, I'd like to introduce Jennifer Solomon and ask her to make a few remarks. Jennifer serves as a public health analyst at the Substance Abuse and Mental Health Services Administration. She is a passionate advocate for bringing attention to substance abuse issues affecting older adults and oversees the prevention portion of SAMHSA's State TA contract. Jennifer has been invaluable in helping us bring this webinar series to all of you. Jennifer?
Thank you, Mary Ellen. SAMHSA is thrilled with the response to this webinar series and recognizes the importance of partnering with other federal agencies, states, and communities that work with families and caregivers to prevent substance abuse and misuse in this population. We encourage state prevention directors to examine their data. I will now turn things over to Dr. Frederick Blow.
Hello, everyone. Thank you, Jennifer Solomon, and also to SAMHSA for sponsoring this very exciting seminar series on a topic that I think is really important and will be continuing to grow in importance in the future. Also, thanks to Mary Ellen Shannon and all of the folks at JBS International for sponsoring and all the logistics support for the seminar series. Today, I'm going to talk about SBIRT for older adults, but first, a few introductory remarks. The first is that there are very few evidence-based substance abuse prevention programs that focus specifically on older adults. It's one of the big challenges in the field as we think about this growing population. And if you go back to the first webinar, you can learn more about the rates of both alcohol and other prescription drug and other problems facing older individuals, and recognize that our baby boomer population is rapidly increasing in terms of the risk for substance misuse. And we need to be able to have better prevention strategies going forward to address this growing problem. Unfortunately, there aren't many, and so we're going to focus on two evidence-based programs today. First is around taking action and specifically around SBIRT, screening, brief intervention, and referral to treatment for older individuals, as well as a program that Amy Miller is going to talk about, her Senior Reach program, which is an exciting outreach program for seniors in the community. And then we're going to spend some time, Christina Economos is going to talk about the steps to evidence-based approaches, using a model that was developed by the Institute of Medicine using a public health so-called LEAD approach to evaluate programs that I think will really lead the way, as it were, to developing new evidence-based procedures and programs for preventing substance use and misuse in later life. I wanted to point you towards this really excellent resource guide that was developed by SAMHSA, and to point out that in our previous webinar, the third webinar in the series in particular, we talked about using data and mobilizing partners and collaborating and planning. And today we're going to focus on selecting and implementing programs, and there's other things within this guide that will be very informative to you. I recommend you go to the samhsa.gov website. You can easily obtain this and use it in guiding your programming efforts. So I wanted to just spend a little bit of time on screening as the basis for SBIRT, and then talk a little more about the uniqueness of SBIRT, the evidence related to older adults and use of SBIRT. So things you may not know about, even though you probably are pretty familiar with SBIRT within your states. And then finally, I'm going to talk about very broadly some of the key elements of SBIRT and how to think about them and apply them to older individuals. So first, around screening, really this is a fundamental issue that is very important for older individuals, in that many older individuals are hidden. They're in our communities, but we don't see much of them often. The people with more subtle problems that are either homebound or just not active in the workplace, or other locations where younger people are often detected, older individuals often are not in these locations, so it's a little more difficult to identify them in community settings. There are also a number of barriers to identification, including ageist assumptions about what an older person looks like who may be having problems with alcohol or other drugs. We believe that sometimes we assume that memory problems, for example, are the norm for older individuals, when in fact it may be related to other issues related to substances. We also fail to recognize symptoms, and symptoms are more subtle often in older individuals because of their special vulnerabilities. We covered that in the previous webinars, but I wanted to highlight it here because it's hard to recognize sometimes whether people are having difficulty. So even in just assessing the need for services in communities, it's often difficult to identify individuals who may be at most need because of these more subtle symptoms. There's lots of lack of knowledge about screening. The idea that people will not be forthright in telling you about what they're drinking or other drug use is like is false if you do it in a sensitive and positive way. The attempts at self-diagnosis or a description of symptoms can often be attributed to an aging process or a disease, as I suggested. So sleep disturbance can easily be attributed to aging issues when in fact it may be because people are drinking too much, especially later in the evening. And then finally, an important issue is that many older people with substance misuse don't self-refer or seek treatment. And even though most older adults, up to 90%, see physicians regularly at least once a year, an estimated 40% of those who are most at risk don't self-identify or seek services for substance abuse, and therefore our full spectrum of services ranging from prevention all the way to treatment are often underutilized by this very important vulnerable population. There are a lot of signs and symptoms I have an example here of alcohol problems, but one could use other substances within the context of this: prescription drug misuse, cannabis use, other things for older adults. And as you see here, perhaps with the exception of increased tolerance to alcohol, the symptoms and signs are very broad. They really cover a lot of ground, and if I had put up the words of dementia, one might think about some of these problems, or whether if I put something like depression up, you might think about a lot of these problems. So the non-specificity of these problems in older individuals means that systematic screening is really important if we're going to really identify people early and intervene early, hence the need for thinking about rigorous screening and assessment tools that have been validated for older individuals. When you're doing screening, you want to not just focus on consumption, but also consequences, or vice versa, just focus on consequences and not consumption. The Odyssey is a very good instrument, easily available online. It's 3 questions. It has to do with frequency and quantity of use. The full audit for alcohol consequences, 10 items, very easily used, also validated for older individuals. We developed the Michigan Alcohol Screening Test, the geriatric version, and that is a good measure for alcohol consequences widely used in a variety of settings. And then there's also something called the Health Screening Survey, which is a screening survey that embeds alcohol use within the context of other nutrition, exercise, smoking, and depression elements, and is often used in the context of a health visit, can be combined with other things. In some ways, older individuals are very receptive to having these kinds of questions embedded within a regular health assessment. There are other tools that have been developed that I want to point to. All of these are available easily online, and this is a series of tools that embed alcohol questions with prescription drug questions, and some of them are a little complicated to score, but the computerized version is a really good version to be able to identify people who may be having problems with their use of alcohol, their drinking, as well as their use of prescription drugs. It combines screening assessments with health education, and I think is a really good overall strategy for identifying people in a whole range of settings. We often think, well, the most ideal settings for older individuals are in healthcare settings, but in fact, we have done screening in lots of community settings and find really large numbers of people who endorse having some difficulty. So I really encourage people to be thinking more broadly about where to screen and which individuals to target for screening as you go forward. And as you do planning, to try to think through, not just the emergency department, which is where a lot of the expert work has been done, but also through other kinds of settings. We'll talk a little more about that in a minute. So what are the screening and assessment recommendations? So the SAMHSA Treatment Improvement Protocol, the tip number 26, which was published a number of years ago, currently in revision. I chaired both of the committees. The recommendations from that tip was that every person over the age of 60 should be screened for alcohol and prescription drug abuse as part of regular physical examination, and to use the so-called brown bag approach, which we don't have paper as much in some communities, but certainly having older people bring in all of their medications that they're currently taking in a bag so that each one can be reviewed, and for disused medications can be discarded, and to confirm that there's no medication-medication interaction. So really an evaluation of the problematic use of drugs, and then an assessment around alcohol, very powerful, with, for example, sleep or other problems, or if the person's undergoing major life transitions like death of a spouse or retirement, for example, you want to screen again. These are trigger points for people often to increase their use and start developing problems. We know about a third of individuals with severe alcohol problems start those problems later in life. So there's real opportunities to do targeted prevention, early identification, prevention strategies if one can do systematic, universal screening that's combined then with selective stratification or selective intervention strategies that would really help with changing the course for individuals as they age. So often people ask me, well, I'm too embarrassed to ask my grandmotherly person in front of me personal questions about their drinking or personal questions about their drug use. Well, in fact, these are no more personal than a lot of questions that are asked. And you know, what you need to be doing is asking direct questions. You want to preface the questions with a link to medical conditions or concerns about their health or concerns about their well-being. And I find and have found in just really many settings that older individuals are very forthright and have no difficulty with saying what they are thinking, and to be very disclosive if the person asking the questions approaches them with a open-ended and positive kind of demeanor. Don't use stigmatizing terms. It's really important. People are very much reactive when confronted with being called an alcoholic or a problem drinker. So really just talking about consumption in a more matter-of-fact way. So on to SBIRT. So probably most of you are familiar with SBIRT, Screening, Brief Intervention, Referral to Treatment. I want to point out that SAMHSA's Substance Abuse Prevention and Treatment Block Grant funds for the prevention set-aside can't be used for SBIRT, but you can still think about SBIRT in the context of a broader constellation of services that are delivered outside of that prevention set-aside. So you can really maybe integrate this with other kinds of funding to be able to accomplish it. But nonetheless, I wanted to also talk about, what are we talking about when we think about target populations? And I'd like to show this graphic because it illustrates very nicely to me the relationship between alcohol use and alcohol problems, and our typical emphasis on those that have the most severe problems and the heaviest use, and that is the dependent or alcohol use disordered individuals. And this is the tip of the triangle. And what I would argue is that if you focus on that tip of the triangle vis-a-vis older adults or aging, you're missing the boat, because the reality is that most older individuals, because of the interactions with chronic illness and medications and other things related to normal aging, are going to fall in the at-risk or problem use categories, and you need to be thinking about the middle part of the triangle if you're going to be thinking about preventing problems and intervening early for problem use. So really not just focusing on the most severe or referral to treatment piece, but the broader spectrum. This is another way to think about the spectrum of interventions for older adults. I always like to show this because we don't want to forget about prevention, and we also don't want to forget about formal specialized treatment. The brief intervention element here really can cover a wide range of people in terms of the kinds of issues they're facing, all the way from light drinking that may be contraindicated because they're taking opioid medications, for example, all the way to severe or chronic problems related to substance use disorder. But there's also other elements to this that are important to remember, and that is sometimes targeted brief advice can be effective and used very specifically for individuals who may need a little bit of a boost. And then these pre-treatment interventions to try to prepare people for treatment can also be very effective. But today I'm talking about SBIRT and those brief interventions as the core issue that I think is the best evidence we have that are effective in terms of early screening and identification and intervention. So who can conduct these brief interventions? You are aware of all of the health professionals that have been used in a variety of SBIRT settings, but I want to encourage you to think more broadly vis-a-vis older individuals and people like home health workers or other allied health workers, or individuals in a variety of social service settings. In the Institute of Medicine report that I was part of, focused on the geriatric mental health workforce, we really tried to emphasize the importance that in order to address the substance abuse and mental health service needs for older individuals, one needs to be thinking about the broad array of individuals who come in contact with older individuals that may be great intervention locations or opportunities to be addressing their use of alcohol and other drugs. And those can include a variety of personal health aides, as I say, home health workers, et cetera, rather than just the more advanced trained individuals like physicians or nurse practitioners. If we're going to really make a difference, we're going to be needing to think much more broadly about who might come in contact with older individuals, housing managers, congregate meal site managers, senior living center managers, a whole range of individuals that could really make a difference in terms of the course of these problems as people age. So what are some of the settings? Again, you've probably had a lot of exposure to the healthcare settings and workplace settings, but really encourage you to think more broadly around that, around congregate housing. We've done interventions in group housing settings for older individuals, as I say, senior centers, and even substance abuse treatment programs where it's often challenging for older individuals to engage and to be part of that. So really thinking about these interventions as ways to help motivate individuals. So what are brief interventions? Well, they're time limited, typically 5 to 20 minutes, but they can also be brief sessions, and up to 5 brief sessions is kind of the norm. People often think about SBIRT as just being this one-time 5 to 20 minute intervention. Actually, you could think about it as short bursts, short sessions over a period of time, and they target a specific problem, whether it's alcohol or prescription psychoactive medications. Those kinds of things are relevant and are evidence-based for older individuals. The goals are to reduce use, potentially to facilitate getting additional treatments. That's the referral to treatment, RT. And it relies on the use of screening techniques, as I suggested. So there have been 2 early studies that were conducted on brief interventions for older adults. One was in Wisconsin that was physician-delivered advice, a smaller study, but showed significant effects at 12 months. The second one was the one that we did at the University of Michigan, and this was a elder-specific motivational enhancement conducted in home. We decided we really wanted to try it out in people's homes, and that also reduced at-risk drinking at 12 months. And then there's been a couple of other studies that have been done since then that have really demonstrated that these are very effective for older individuals, that these are really good strategies to try to think about intervening early. I wanted to talk about the PRISM-E study briefly. This is the primary care research in substance abuse and mental health for the elderly that was sponsored by SAMHSA. That was a study to try to understand how do you deliver at-risk alcohol use intervention, the SBIRT, for older adults in primary care. It tested two service models, integrated collaborative care, which was a co-located, concurrent, collaborative care within primary care setting, versus an enhanced referral. They basically referred individuals to specialty mental health and substance abuse clinics, and through preferred providers and facilitated appointments, transportation payments, et cetera. I was actively involved in this project. I trained all the sites in terms of the alcohol brief intervention. So really was, I think, an important implementation study to try to understand how would this work in real life. It was a randomized trial. It compared directly integrated care to referral care. There were 3 conditions targeted. I'm going to focus on drinking. There was a screening phase, a baseline assessment, and then follow-up assessments up to 6 months. And what was found in the PRISM-E study is that there was greater engagement in care for those that were in the integrated care arm, which means that what older people want and need is right where they are. They don't want to have to go someplace else to get these services. They want to have the services delivered wherever setting they happen to be in. And I think this is really instructive as we think about developing prevention strategies and implementing them in our communities. Notably, in the integrated care, we did everything we could possibly do to try to enhance the likelihood that the providers would be actually delivering this intervention. And of those 120 participants who received 1 session of brief intervention, we wanted them to be continued out to 3 sessions. Only 24 people, 9%, got the 3 sessions. It's very challenging to do this in a regular setting. And then secondly, there were significant reductions in the quantity and frequency of drinking and binge drinking over 6 months with no differences between the models. They could be done in integrated care or referral care. However, there was minimal uptake and implementation of brief alcohol interventions in both study groups. This is really important to highlight that we need to be thinking smartly about how we implement, how we really design services and design them for our communities, whether it's in primary care or other healthcare settings or in other settings outside of healthcare. It is a major challenge to try and get these kinds of interventions implemented in a high fidelity way in these wide range of settings. So the major components, I just want to spend a few minutes on brief interventions of a screening and brief intervention program is screening, developing feedback, providing feedback, trying to motivate people to change, giving people ideas about strategies to change, be a negotiated agreement, and then doing follow-up. We typically use a workbook to be able to deliver these interventions. They're guided with a very short workbook. Those are easily available online. Again, I recommend the SAMHSA.gov website. Also, the NIAAA.gov website has a clinician's guide that is very productive and very useful. You'll see some more about references and materials that you can access at the end of the webinar today. So what are some of the elements of brief interventions? We like to use the FRAMES model, and this is basically feedback, responsibility, advice, menu, empathy, and self-efficacy. I'll go through each of these very briefly. Feedback is basically providing information to the older individual based on what you've learned from them. If you screen them, you have some information about what their screening is like, But if you have other healthcare information or other kinds of information, you can also provide that feedback. It helps increase awareness of the adverse consequences of their use of substances, and it helps make the case for changing in drinking or medication use or illicit substance use. The second is responsibility. Older adults the older person is essentially, we're all ultimately responsibility for our own change. The person delivering the intervention can't force anyone to change, whether it's an older person or a younger person. And the older person needs to be encouraged to choose their own goals. They need to be realistic. They need to really what the practitioner or the intervener could do is help clarify the client's goals. But basically, this is an opportunity to help develop a discrepancy from where the person is versus where they want to be. And Lucy sort of illustrates that in this cartoon. You want to provide advice and a menu for change. You want to give clear and concise, concrete advice to change. Typically, 3 choices are great because people will, give some, be able to choose. We all like choice in our change behaviors. And making choices, the first step is really, that's the first step in making a change in behavior. So lose some weight, quit smoking, move around more, and eat a carrot. So, and then finally, really a couple of more other things, which is empathy. You want to really actively listen. You want to listen carefully. You want to clarify what the older adult is saying, what they mean, and you don't want to impose your own values on the older adult. People are really sensitive around this, and it's really important as we go forward to make sure we recognize that behavioral change is hard, and it's not easy for older people either. And then finally, self-efficacy. You want to build up the older person's belief in their ability to succeed. Always be optimistic. Provide some simple goals early, because early success breeds other success in changing, and then it increases self-confidence also. So in summary, what do we know about current knowledge? Well, we know that brief interventions can reduce alcohol use for at least 12 months among older adults. There's good evidence now that in a variety of settings this can be done. That motivational enhancement for older individuals is very effective. We didn't know that early on, but it certainly is. And that the approach is both acceptable to older adults and can be conducted in health clinics and in home and now in a variety of locations. These brief interventions appear to reduce alcohol-related harm. There's some evidence that there may be decreased healthcare utilization also. So for a large portion of individuals, this early identification, early intervention can make a big difference. However, there's also a huge problem with implementation, the so-called implementation gap. There's national imperatives to implement evidence-based practices. That's why we're having some of these webinars. But we know that there's a science-to-service gap, that scientifically proven effective practices are not widely used in our states, in our communities. And we need to really increase the likelihood that what we know in terms of the science will get translated to service. And then there's also, I've alluded to this, the implementation gap, and that is that we often find positive outcomes achieved in research, but they're not often replicated in the field, and that's related to poor implementation, where the fidelity to the actual practice is not kept, or other reasons. So we need to be paying attention to that too. Both effective interventions and successful implementation are absolutely critical for positive outcomes, and we need to be paying attention to both of those things. So the take-home messages from my presentation today is that prevention in the form of early identification of and early intervention for substance abuse in older adults is absolutely critical and doable. And then for those that with serious problems, we haven't talked much about that today because I focused mainly on prevention and early intervention. But for those with more serious problems with addiction, with substance use disorders, we know that for older individuals, treatment works, and we want to encourage people to actively seek treatment when they need it. And then finally, I wanted to say that our national focus on mental health and substance abuse prevention and treatment is really critical, and it's critically important as the baby boom generation reaches later adulthood. We made that case throughout this webinar series. It is a very large problem, and we need to be really focused on it. And so with that, I'm going to turn it over now to Amy Miller, who's going to talk about the Project Reach, Senior Reach, sorry.
That's all right. Thank you, Dr. Blow. All right. Well, thank you. I'm very excited to be here today to talk about the Senior Reach program. Again, my name is Amy Miller, and Senior Reach started in 2005, and it really started with the mission of supporting the independence and the well-being of older adults. And we do that through community education, the provision of behavioral health and care management services in the home, as well as connection to other community resources that the older adult may be needing. And the goal of Senior Reach is really to use collaboration, to tap into the resources that already exist in the community, the services that are already there, and enhance collaboration among the service providers to reach those who are most isolated and who may not be able to or know how to seek treatment on their own behalf. So we have three key components of the Senior Reach model. The first is community education and outreach. This is where we go out and we train individuals in the community about the behavioral health needs of older adults, the warning signs that someone may be struggling, may be needing extra support, and information on how they can get that person connected to services by making a referral to Senior Reach. And we focus on training both traditional community partners, so those people who work with older adults in a professional role, primary care offices, home health agencies, senior center staff, as well as the non-traditional community partners. So these are people who are interacting with older adults just as, regular members of their community. And a non-traditional community partner could be someone from their faith community, a neighbor, a family member, the wait staff at the local restaurant that's really popular with older adults, hairdressers. Often these are the folks who are the first ones to notice that something isn't quite right, that so-and-so isn't showing up for coffee on Tuesdays with their friends anymore, or isn't showing up for their weekly hair appointment. And, they're often concerned, but they don't quite necessarily know where to go. It may not warrant a referral to Adult Protective Services, for example, but they just want to make sure that someone's reaching out and able to connect that person to services they need. So Senior Reach is really able to meet that community need and empower them to know where to go to connect the older adult to services. And that happens through the screening that takes place on our referral line. And it's a single entry point, so no matter what they might be needing, behavioral health, care management, both, maybe a referral to other services like transportation or Meals on Wheels or minor home repair, that can all happen in the referral line. So the referral line receives the referrals from members of the community and then reaches out to that older adult and gets to know them, gets to know their story, and explains what services are available to them. And even though we're working mostly with individuals who are not seeking services on their own behalf, we have a published acceptance rate of 93%. So even though they weren't asking or looking for these services, once they know what's available through Senior Reach, 93% end up accepting those services. At our individual program, in certain years it's gone as high as 98%. As time goes on and we build those partnerships and relationships in the community, and more people feel comfortable describing the program and making those referrals, we see a lot of really great connection to services with older adults. And those services that Senior Reach offers include home-based, short-term, brief interventions with behavioral health and care management. So again, we go to the older adults. We always offer services in the home, although we will meet with them in their preferred setting. If they'd rather meet at a library or a church, whatever that might be, we will go to them and take away that barrier of potentially having to walk into a mental health center. And we provide up to 12 sessions of behavioral health or care management services. On average, most people engage in about 6 sessions. And so, again, because we're identifying people early before a crisis has developed, with a brief amount of intervention, we're really able to give people resources, coping strategies, information, and then we can step back and they can take the tools they've learned through Senior Reach and use that to, go about living their quality lives that they've been wanting to live. So with our program here, we are a partnership between two mental health centers that serve 5 counties west and northwest of Denver, Colorado, as well as Seniors Resource Center, which is a local nonprofit that focuses on serving older adults through programs like home health care, chore services, adult day programs, and care management. So again, the idea is to tap into the resources that already exist in the community. The mental health centers provide the behavioral health. Seniors Resource Center staffs the referral line and provides the care management services. And we've just strengthened our collaboration so that older adults aren't falling through the cracks of a very kind of disjointed, difficult to navigate system. And so with this delivery model, we're really able to see some fantastic outcomes. We see a decrease in people's overall symptom severity of their mental health concern, decrease in their emotional disturbance, a decrease in symptoms of anxiety and depression, a better ability to focus on attention, and I think a real key outcome is this decreased social isolation. There's a recent study that came out of Brigham Young University that showed that for an older adult, being socially isolated is as deadly as smoking 15 cigarettes a day. So we know social isolation is just a major risk factor for all sorts of negative outcomes for older adults. And with all of these outcomes, these are all risk factors for an older adult developing a substance use disorder. So the fact that Senior Reach is able to get in early, help that older adult find those other coping strategies and see these improved outcomes, I think speaks very highly to its ability to address this need for substance use treatment for older adults. The other outcomes we see, overall level of functioning is improved. There's a better ability to meet their basic needs, so they're able to stay independent for longer. We see them getting more involved in healthy activities, improved social relationships, improved interpersonal relationships, and I think a real key one is, an increased sense of empowerment and hopefulness about the future and their overall recovery. So as Dr. Blow mentioned, there's a real need to avoid the stigmatizing language and help those older adults feel empowered so that they are engaged in treatment and they're seeing those better outcomes. That's definitely an outcome that Senior Reach has seen from its inception. And so that's the evidence-based model. Our program here at Jefferson Center has had some enhancements over the years. Like I said, it started in 2005. And so as the years have gone on and we've seen different needs in the community, we've added wellness services, which includes classes and home visits around issues like chronic pain, grief and loss, sleep hygiene, social isolation. We come at this from a variety of different ways, including classes on bullying in retirement communities, having healthy friendships and setting boundaries. We work with a lot of clients on family conflict. So there's a lot of different ways that Senior Reach can intervene, and we really do take that holistic approach of not just focusing on what's the diagnosis on their chart, but what are all the things going on in their life that might be impacting their quality of life. We've also added senior peer counselors so that as clients finish with their clinician in their episode of care, they may not need clinical treatment anymore, but that's a nice extra support that we've been able to add on, so a person can get weekly visits for up to a year, so that as they're starting to practice the coping skills they were given and use some of these tools that they worked on with their clinician or care manager, they have that connection and extra support. We've also gotten additional funding to offer caregiver support. So these are counseling sessions that are available at no charge through our local area agency on aging for individuals who are caring for someone with dementia or another neurodegenerative condition. Some other enhancements that we've seen, we've gotten grants to enhance our ability to serve our mountain communities. So this can be a real challenge for someone who is literally living on top of a mountain in Colorado to, drive safely down these very treacherous roads sometimes to get to an office for behavioral health. So we've been able to fund a position where our clinician will go out and provide Senior Reach services, again, home-based in the home, to these clients living in the mountains. And we've seen some really great outcomes there, and we've been really grateful to serve those folks who are traditionally very underserved. We also have a grant in partnership with Jewish Family Service to serve one of the naturally occurring retirement communities in the state, or we call them NORCs. And the idea with NORCs is that we've identified communities that have a large number of older adults, and rather than waiting for them to have to leave to receive services and, for example, in assisted living, we bring services right there to the community on site. Care management, Senior Reach provides the behavioral health services, and in that way we're able to keep people independent in their community for much longer. We also have some additional funding from our local area agency on aging to support those who are low income, may not have health insurance. We've got specific outreach to different minority populations. Here in Colorado, it's largely the Latino community. And so over the years, again, as Senior Reach has been able to build these partnerships and enhance collaboration within the community, we've gotten a lot of really great support from different funders, and we've been able to provide some really fantastic services. There was a funding opportunity that opened up recently through a local foundation that was really looking for ways to innovatively support older adults in living their best lives. And we know the Senior Reach model is innovative. We're practicing in a way that isn't traditionally done in terms of reaching out and identifying those who aren't seeking services on their own behalf. And so we were really looking at, what was the unmet need in our community that Senior Reach could start to address. And substance use for older adults definitely came up for a couple of reasons. Colorado is the fastest aging state in the country, and here in Jefferson County, which is by far the largest county that we serve in our Senior Reach program, we have the largest number of older adults in the state of Colorado. So we know it's going to be a growing need just by sheer numbers, but then certainly up into the mountain communities, we see higher rates of heavy drinking, binge drinking, and higher rates of heroin and opioid death rates. So we know there's a real need for education, outreach, and treatment up in those mountain communities as well. So in deciding how we might go about addressing this need, we of course looked to SAMHSA and the tip sheet on providing substance use treatment to older adults. And we were struck by how many of the key recommendations really fit in beautifully with the Senior Reach model. Using a least intensive treatment option. Definitely Senior Reach fits that model, as well as the brief intervention model. They do recommend interventions. That's not something that Senior Reach at this point would be equipped to do, but that was really about the only thing that didn't fit in with the model. We definitely use those motivational interviewing strategies. And again, we are definitely coming at it from a non-confrontational, supportive, empowering mindset from our clinicians and our staff members. So some of the other practices that the SAMHSA tip sheet recommended, again, the brief intervention that focuses on reducing social isolation and helping people find healthier activities. Well, we know those are two really critical outcomes that the Senior Reach model delivers. Learning how to cope with social isolation, negative family interactions, boredom. Again, we see those outcomes of decreasing social isolation, improving interpersonal relationships, improving activity involvement. We've always employed an expert model that is part of our intake process, as well as for clients who are becoming clients of Jefferson Center. Everyone is screened through the expert model, and we've always been able to refer those folks to the substance use disorder treatment. Our goal is to really be able to provide more of that treatment ourselves frontline in the home. I loved that SAMHSA recommended using case management services because, again, we know that there's a wide variety of needs in the older adult population, and if someone is concerned about losing their housing and they don't know where they're going to be sleeping next month, it's going to be hard to effectively address their substance use or their mental health condition. And so, with Senior Reach, we train all of our sites with Maslow's hierarchy of needs, right? And we recognize that we have to meet those immediate needs before we can address some of those higher level behavioral health or social needs. And so the fact that care management is built right into the Senior Reach model makes it really possible to have the best possible outcome. Again, we're really taking that holistic approach and looking at all of the things that might be impacting them and looking at it through a lens that appreciates the unique challenges of later life, the health problems that can come up, the different losses that can impact someone's sense of social isolation. And again, with the SAMHSA recommendation to address the ageism and the lack of awareness about the fact that substance use exists in later life and treatment is effective. The wonderful thing about community education and outreach being built in to the Senior Reach model is we're able to train not only the community but also professionals about how they might go about screening and where they can then go to. You know, we put a lot of emphasis on screening. I think the great thing about Senior Reach is that then we can give all those professionals who've been told to screen for things the place to refer for services in a way that, again, breaks down some of those barriers in terms of transportation or, you know, maybe they have an oxygen tank and they can't go out for more than a few hours at a time. Again, we can go to them and address some of those barriers with the Senior Reach model. And we absolutely use validated screening tools. Those are built right into our Senior Reach database, which is where we're able to capture all the data on the different outcomes we've achieved. So our plans to really enhance our ability to address substance use disorders in older adults include training clinicians. We've got a very highly skilled staff, and we know that they're already seeing this with a lot of their clients, but we want to just build their confidence and refine their skill set in being able to provide that treatment directly for those clients who have a substance use disorder as their primary diagnosis. Definitely our plans to use our wellness program, both as an avenue to provide that outreach and screening and prevention, because we are addressing those risk factors like chronic pain, sleep hygiene, grief and loss. So using that as you know, the prevention and early intervention model, but also using them as complementary treatment for those older adults who might be receiving substance use disorder services at Jefferson Center, you know, being able to offer those wellness programs as additional treatment as well. And then because there is a higher need in our mountain communities, definitely using that mountain clinician position to be able to provide that education and outreach up in the mountain communities, and again, provide that substance use disorder treatment within the Senior Reach model, because we know it's definitely more accessible than some of your traditional outpatient community settings. So again, the real benefits of Senior Reach in terms of being able to address substance use disorders in older adults, we are being assertive in our community outreach. We're going out to the community, training them on what to look for, which helps us screen, identify, and intervene early, again, before the crisis develops. Give people tools they need early on before they start turning to a substance to help manage their pain, their grief, whatever it is that they may be going through. Another real benefit is being able to have a framework that is able to identify those who are most isolated, most vulnerable, most disconnected from the traditional service provider community, and being able to engage those. Again, we have a 93% acceptance rate, so we have that skill set built in to be able to engage those folks that have so far fallen off the radar. Taking the holistic approach, again, identifying all the needs that a person might have and being able to address them through the care management services. And again, with our clinicians, with our wellness services, we're looking at every aspect of the person, neuro, bio, psychosocial, spiritual, because again, the needs in later life are very complex. Often there's trauma in the person's past that has never been addressed until, you know, the first time the Senior Reach clinician walks through the door. And, you know, with later life can come some really challenging existential issues. And so we're able to have all of that in mind as we're working with that older adult and letting them guide what their goals are, what they want to achieve with their time in Senior Reach services. And another great thing about the Senior Reach model is it's very flexible. We have 12 additional sites. We have 2 other sites in Colorado. We've got 9 sites in Michigan. We've got a site in New Jersey that's getting up and running. And it's been fantastic to see, you know, each individual community identifying who their stakeholders are, you know, what services are there, what are the gaps, how can they creatively and efficiently fill those gaps. And so, you know, different sites are really able to make Senior Reach their own in a way that meets their unique community's needs. So that's been really fantastic to see. So again, with Senior Reach and its ability to provide substance use disorder treatment, I think really the key takeaway is that Senior Reach lets you leverage the benefit of engaging older adults who aren't seeking treatment on their own behalf, or who have barriers like Dr. Blow mentioned in terms of transportation or stigma or whatever the case might be. And our goal is to take those proven outcomes and really shine that focus on individuals with substance use disorders as their primary concern and be able to meet their needs. This is my contact information as well as our Senior Reach website. And so I'm happy if folks want to reach out individually. I know there will be some opportunities for Q&A through this webinar as well. But I want to thank you for attending today, and it's been a real pleasure to be able to talk about Senior Reach with you.
Hi, everyone. I'm Chris Economos, and today I'll be talking about a framework that I was part of developing called Finding and Using the Best Evidence Available to Inform Decisions, the Institute of Medicine's LEAD framework. And LEAD stands for Locate, Evaluate, Assemble, and Inform Decisions. This was developed in 2010 through a consensus committee. So we all know that policymakers and practitioners who want to take action to address an epidemic need evidence to explain why the actions are needed and to help determine what actions to take and how to go about them. They also need evidence to determine whether the intended results are obtained, who benefits, and whether there are positive or negative effects that deserve attention. Now, when we're in these situations and dealing with a public health crisis, ideally, there would be ready sources of such evidence at hand relevant to these information needs. But this isn't always the case. So this framework was developed to assist decision makers in finding evidence to inform their decisions, as well as to help researchers determine useful areas of study, often with either incomplete or a less than ideal evidence base. So this framework was developed with obesity prevention in mind, but during the process, we were very thoughtful so that this framework could be applied to other public health problems or areas. And so I'll be talking more generally today about what the framework looks like, the kinds of questions you can ask as you're using it, and how it could apply to any public health issue or crisis. So I'll discuss what the LEAD framework is, why we need it, how it works, and then I'll illustrate by using a case study to show you how different types of evidence can be brought together. So the framework that we developed helps to answer two fundamental questions related to the needs of two primary audiences. So in terms of the questions, it's really how can evidence that is currently available and potentially relevant to decisions about a public health issue be identified, evaluated, and compiled in ways that will best inform decision makers? And second, how can more evidence be developed that is of high quality and framed to be directly relevant to decision making on a health issue? So the report is really designed to address two primary audiences, decision makers and their intermediaries who assist them in making decisions, as well as researchers and evaluators working on a particular health issue. So the committee consisted of researchers as well as practitioners and policymakers who really had an eye toward how valuable this report could be when they were using it for a particular public health issue. It's important that I give two caveats. One is that the framework does not offer shortcuts that can provide any type of high-quality evidence as rapidly as one might need it, but it offers suggestions or ways to increase flexibility and broaden perspectives and still maintain the concepts of what makes evidence credible and useful. And the framework is not an algorithm that can be used to make decisions, but it's a framework for using evidence to inform decision-making. So the first thing is that we're encouraging anyone working with a particular public health issue to use a systems perspective. And this means that each aspect of decision-making and research should be approached with an appreciation of the complex context and the many factors that influence the health issue. And in the two previous presenters, you heard a lot about context, where someone is, what particular geography they live in, what types of resources are available, what the culture might be like. And it's always important, even when looking at very specific evidence, to appreciate the context and the larger system. In the case of substance abuse, particularly at this particular point in time, we have federal attention, we have federal policy and resources that are emerging, and that's an important context to keep in mind. So first, it's important to think about both locating evidence and evaluating evidence, and beginning with identifying the questions that need to be answered for a particular decision. I'll get into this more in subsequent slides, but oftentimes there are multiple decisions that need to be made. For example, what type of program will we apply? What type of evaluation will we do? What types of policies do we want to influence in the process? How many people need to be reached, et cetera? So first, really specifying the questions will then lead you to the types of evidence that need to be gathered in order to particularly address the question. The next is to identify the potentially relevant and useful sources of evidence and to evaluate each source of evidence appropriately. I'm going to spend a little bit of time on this slide because I think it's really important to talk about the types of evidence, and this is what we wanted to emphasize in this report. As I mentioned at the beginning, there's often a crisis with incomplete evidence and yet an urgency to act. So as policymakers or practitioners, we certainly don't want to wait 5 or 10 years until a series of randomized controlled trials might give us the best or high quality evidence. We want to act soon to respond to the crisis. So what can we identify and evaluate as evidence to help us make the best possible decision? So we created 7 categories of study designs and sources of evidence that on their own all require a certain quality standard to be applied and a relative value of quality, and that will really depend on the type of evidence. So let me share a little bit about the types of evidence we're urging people to consider when they're making very important non-experimental or observational studies. So this is an evidence base that consists of cross-sectional, longitudinal, or retrospective survey research. It could even include opinion polls, trend analysis, market research, or secondary analysis of existing database, cohort case control studies, consensus studies, surveillance studies, policy analyses. These would all would fall into non-experimental or observational studies, and often pretty high quality evidence comes from those. The second would be experimental and quasi-experimental studies. So the obviously gold standard, randomized controlled trial, or matched cohort study, regression discontinuity, or interrupted time series design. These are all very high quality and often produce excellent results. But again, in an emerging public health crisis, we often don't have time to wait for a whole series of these types of studies. So we'd want to start to see if they exist and then broaden our search using the other types of evidence that I'm running through. So the next is qualitative research and analysis. So this is logic modeling or program theory analysis, ethnographic studies, focus group or key informant interviews, or even looking at intervention process delivery and implementation monitoring. The next is mixed method studies, where you actually might combine surveys and interviews with randomized controlled trials, or interviews combined with interrupted time series analyses, economic analyses using archival databases and surveys, or systems mapping, which I'll actually use as part of my case study. The next is evidence synthesis methods. So these are systematic reviews or meta-analyses of experimental and/or quasi-experimental studies, or even mixed method evidence syntheses. The next is parallel evidence. So this might be an indirect form of evidence where you're looking at another public health issue that use similar strategies and trying to see what can be gleaned from those experiences. They may have implications for the work that you're doing in substance abuse. And last but not least, expert knowledge. And this includes the views of professionals with expertise in a particular field of practice or inquiry, such as clinical practice or research methodology. So this may be one person's views or the consensus view of a group of experts. And it may not be the evidence that is enough to draw a conclusion, but in the absence of any other evidence or to complement some other narrow evidence, it can be extremely informative. So for each of these, as I said before, they have to be recognized as a source of evidence and absolutely go through the form of quality review that is available for the type of evidence that you're talking about. So this together enables you to locate different types of evidence that are out there and then apply the standards and the quality to evaluate the evidence. The next two steps are assembling the evidence and then informing decisions. So when it comes to assembling the evidence, it's important to develop a transparent and comprehensive summary of all the available evidence. There may be quite a bit of rigorous evidence available, and it might be fairly thin or weak, and being transparent about what you have and what you don't have is extremely important. And if the evidence is limited and action is needed, really examining the potential to blend the limited evidence with theory, professional experience, and local wisdom. Again, acting in its crisis situation is often necessary. And this is really what can be informative to the decision-making process. So what you want to include is a summary of why the action should be taken, what type of action to take, and how it should be taken based on the evidence that's been reviewed. The other part of this framework we felt that was really important was instruction about generating evidence. So each step of the framework offers opportunities to generate useful evidence for decision making. So whether it's evaluating the literature that exists and reporting on the generalizability of the research or the settings or the context, or trying to summarize what sort of research designs exist and which ones could be useful alternatives, or even leveraging natural experiments that are going on and collecting data along the way to develop new credible evidence when evidence is limited. So this can be used for researchers as well. So moving on to a couple of key questions. Why do we need this in the first place? I've already emphasized that sometimes we have to act even when evidence is incomplete, but the evidence really must be relevant to the user needs and to the real world in order to be useful. So the types of questions that would be asked by a local decision maker when choosing what initiatives to undertake can't be adequately answered without broadening the concept of what evidence is valid and relevant. Because for randomized controlled trials, for example, we know there's a lot of internal validity, but the generalizability often isn't as good. And when you blend it with other types of evidence, you can broaden your perspective about what might work in a certain context. And traditional evidence hierarchies based on, for example, therapeutic approaches to clinical problems aren't always directly applicable to complex public health problems. So we believe that this framework is really needed, again, to take into account all the different types of evidence and perspectives that might exist. I also want to comment on the evidence needed for designing, selecting, and assessing interventions is different from most of the evidence that has previously been collected and analyzed. And those who make policy or programmatic decisions in public and private settings or advise others how to do so must often take action, again, on the basis of what is best available rather than best possible. So these, again, were reasons why we went into developing this framework. Also, artificial simplification of evidence to inform decisions about complex problems can be misleading and may result in failure or harm. And the last thing we want is to cause unintended problems. So just summarizing here, many complex public health problems do require multi-sector, multi-level strategies informed by a systems perspective involving a focus on the whole community, awareness of the broader context in which strategies are implemented, and appreciations for interactions among strategies. Any public health problem that's occurring in the real world is occurring in a dynamic environment, and there are changes happening constantly. And that's why we need to monitor and often respond in real time. And transdisciplinary thinking can help us do that when you bring different experts to the table that are trained in different forms of evidence collection and evidence analysis. So this really shows that there are a whole range of different policies that one might consider enacting when they're dealing with a particular public health problem. And those go from very focused initiatives that are interventions aimed at directly tackling a particular problem or a risk group. In our case, again, it was obesity. And those might be specific interventions that would be applied in an aging center or in a elder services program, in your case, or in a community where many elderly residents live. And then on top of these very focused initiatives that are often drawn from trials, there are many different enablers that are ineffective on their own, but really essential to underpin the effectiveness of other interventions. So they're necessary, but not sufficient on their own. And these are often needed to bring interventions to life in the real world. And then lastly, there's a level of amplifiers. And these are key to shifting the system and the population profile as a whole, but cannot act if the other elements are not in place. So we often think about different levels of policy implementation to really impact a population, or in this case, a big problem like substance abuse. And each of these levels require their own body of evidence and require their own decision-making as you go to implement them within a system or within a community or even within a state. So just using tobacco as an example, the tobacco control momentum really gained steam in the great public health, as a great public health success story of the 20th century. And that really happened when certain states began to combine the evidence from various sources and to mount comprehensive programs on the back of state-level policy changes. So you can see here two of the leading states, California and Massachusetts, really took a tremendous amount of evidence and applied it within a large complex system. And you can see compared to the other 48 states, over a fairly short period of time, they saw a much larger reduction in cigarette consumption. So I want to now go through a couple of key questions and highlight the area of concern and the example of the evidence that might be needed to address the question. So the first is, does the available evidence answer the critical what questions? So the areas of concern here might be intervention theory or logic, causal pathways, links between intervention delivery and outcomes, or unintended or unexpected consequences. So the types of evidence that would be needed for each of these you can see, and I want to point out that these tables that I'm showing in the next few slides are actually available in the report. So I'm not going to spend a lot of time on them, but I'll point to a couple of examples. So for causal pathways, the type of evidence that you would need would be expected direct or indirect pathways linking the intervention to the outcome at one or more levels and for different demographic groups. So that's what you would need to rely on to address this particular area of concern. The next is, does the available evidence answer the critical why questions? So areas of concern might be health burden, health disparities, healthcare costs. And you can see for healthcare costs, you'd need estimates of public dollars currently spent on providing healthcare for the health issue or related condition. So that's actually economic type of data and analyses that you'd want to really rely on there. And the next is, does the available evidence answer the critical how question? And here are things you'd consider like generalizability, which I talked about before, cost benefit, implementation priorities, or potential challenges. So focusing on generalizability, this would be the likelihood of achieving the expected outcomes in different demographic groups and in different communities or regions. So the more narrow the trial that was done, the less generalizability. And again, that's where you might need to bring those results to life by complementing it with different types of evidence and different types of trials that may not be RCTs that have been done more in a public health forum. So in terms of the recommendations and what an audience would get out of using this type of framework, it would help instruct them how to act differently with respect to how evidence is sought, viewed, evaluated, and compiled, to act differently with respect to how evidence is generated and published so that they could be contributing to that. And probably most importantly, it would help a policymaker potentially fund differently. So where are they actually allocating the resources, and who are they training to implement the program? And lastly, from a researcher's perspective, making sure that all evidence collected during different research programs is actually made available. It might not all be published in peer-reviewed journal articles, but there are multiple ways, reports, testimonials, et cetera, to make the evidence available to a wide audience so that when people are trying to make decisions, they can access the different forms of evidence that I described earlier. So in terms of the unique contributions of this report's expanded perspective and view of the evidence, it really presents a comprehensive look at what can be done differently in relation to the development and use of evidence. It describes how one can apply this approach, and it provides a clear justification of why doing things differently is both valid and necessary when you're dealing with a public health problem that's urgent. And it provides links to existing evidence resources. Some of the features of the report is that there's a 4-page report brief, so you can read that very quickly. The entire report is available as a PDF. There are key messages at the beginning of each chapter. There are key action boxes in the executive summary. There's a suggested approach to assembling the evidence, and there are appendices. Specifically, Appendix D has information sources for locating evidence relevant to a particular health issue, including web links. And Appendix E deals with filling the gaps in evidence from practice experience, evaluation, and local participation. So it's quite a long report, but these are kind of key features that you can look to if you want to digest the report in smaller pieces. And in terms of key messages for local health officials, the framework explains how to differentiate and focus the types of questions decision makers might pose to better match these questions with the types of evidence that are available. And also a richer and more relevant and useful evidence base, we believe, will inform and vastly improve decision making, but it won't make the design, selection, and assessment of strategies and interventions automatic or free decision makers from exercising judgment. In the end, judgment will have to be applied. And the use of different types of evidence does not have to mean a compromise in the quality or integrity of local health department actions. So it helps really provide a summary, as I described before, that helps justify a particular decision that might need to be made in the absence of complete evidence. And it can also guide the generation of practice-based evidence. So very quickly, I'm going to run through a case example from some of my own work where I used a systems approach to find out how a whole-of-community intervention worked. So I had completed an intervention that was a controlled trial, and the primary outcome was BMI Z-score reduction. So it was an obesity prevention trial in children. But what I realized was there was a tremendous amount of change that had happened in the community, and I had different data sources that I could look to retrospectively to try to tell the story. So here I was attempting to describe the key aspects and dynamics of social change within a community after they had experienced some success with obesity prevention. The trial was called Shape Up Somerville. So I did this retrospective examination of our model using a systems perspective in an effort to create a framework that could guide future community-based obesity prevention interventions. So you could think about some of the experiences that are happening right now in communities dealing with substance abuse and trying to pull together all the evidence that's being generated to create a new framework so that those moving forward could actually use it. So we did a qualitative systems analysis that was informed by individual and group interviews with key stakeholders and researchers. We also drew on the evidence that we had collected along the way that was more quantitative. So in terms of our process, by collecting all these data, we developed a set of 8 systems effects. So you can really see how each of these microsystems within a community would be important to actually changing the behavior of an individual and reducing their weight. And each of these different effects depicts interrelationships and dynamics of the respective system. So when you put it together, you can see broad systemic linkages among these different systems effects and who the players might be within each system and the processes that were going on to impact an individual child's energy balance and more broadly, social change within a community. So this is what the map actually looked like. And what I really want to point out for you is this microsystem that has a square around it called the task force. So this was the task force within a community that really drove the intervention. And this task force actually linked up to all the microsystems in the community which helped to impact the individual. So there were data collected throughout all of these systems within the community that was necessary in order to impact the individual. So this is a fairly comprehensive map, but I wanted to give you a sense of how we use different forms of data retrospectively to put together a framework or to illustrate the dynamics of community change. So this in itself is a form of evidence. So some of the learnings were this was a confirmatory process, that we need multifaceted, multi-level interventions. We demonstrated complexity in interactions. We identified feedback loops. We identified key sectors, and we informed our subsequent replication studies that we did across the country. So this is really a framework to guide other community-based interventions. So this looks really different than what you might think about traditionally as evidence, but it was a new way of generating evidence that came from a traditional controlled trial that had on its own primary outcome of BMI Z-score. But that couldn't instruct anyone how to replicate that model or how to move it into other communities. So it was a new way of generating evidence utilizing a whole range of data that had been collected. So last but not least, the framework was sponsored by Kaiser Permanente, the Robert Wood Johnson Foundation, and the CDC. And there were many members on the committee, and again, representing academia, public health departments, different policymakers, NGOs. And I will stop there. This is the resource that you can download. Thank you very much.
Thank you, Dr. Blow, Ms. Miller, and Dr. Economos for introducing research-informed strategies to help us reduce substance abuse and related problems among older adults. For those that are interested in learning more, the Bridging the Evidence Gap in Obesity Prevention, a framework to inform decision-making, is available online at this website. Another resource you might find useful is SAMHSA's Get Connected Toolkit, available for free in SAMHSA's store and designed to help health and aging service providers learn more about alcohol and medication misuse and mental health conditions in older adults so they can address these issues more effectively. This toolkit will help you build health promotion programs, offers prevention messages, and provides screening and referral for mental health problems and the misuse of alcohol and medication. As promised in the introduction, this is the website where you can view webinar recordings, access PowerPoint presentations, Q&As, and other resources that have informed this series. A recording of today's broadcast will be available here next week. Also, all of the questions submitted today will be addressed in a follow-up Q&A that will be posted to our website in the coming weeks. Thank you for your participation and for all that you do to help address substance use among older adults in your states and communities. Please remember to complete the evaluation, which will appear in a pop-up window once you close out of WebEx. Have a great rest of your day.